الله يعطيكم العافيه.
حبيبي.
تسلم، بارك الله فيك. انا ابغى اشوف الحضور عندي 12 صحيح؟
نعم 12 including me طبعا. احنا we have 11 students. 11 students in this class.
طيب اذا ال 11 انا بعد اذنكم المحاضره هذه اظنها عندكم، واتوقع يعني اغلبكم اذا كان كلكم اطلعتوا عليها. فقدر الامكان حتكون جلستنا اليوم interactive.
Dr. Khalid, by the way, we have one of the students who is not an Arabic speaker.
I see.
Yeah,
okay.
So
fine.
she's asking that if it's possible to have everything in English.
Okay, fine.
Yes.
No problem. I usually like to be bilingual.
Definitely, we love that.
Students, to learn Arabic. It is a very interesting language, and I'm sure you can manage that. What I was trying to say, after thanking Dr. Yasser for this kind invitation, is that today's presentation will be interactive, since I think you have the lecture, and I assume also a video of the lecture. And the topic is not a new thing, and you will notice that I will talk about general concepts before diving into the details of the accent method. And by saying interactive, I assume that you will be also interacting. So I'll be asking questions. When I ask for voting or something, I need you kindly to respond to me. And if I open the floor for questions, just unmute and contribute. So my first question to you, who is aware of this method, accent voice therapy method? Who knows about it or heard about it? Just you can raise thumb up or something like this to know who is aware of this method or heard about it before. Waiting for responses. You can know the Zoom. There is a mark there. You can say yes or no. Are you with me? I cannot see any responses in the screen.
Yes, but I can't seem to find the option for the yes or no. But if I were to say verbally, yes, I've read about it, but I'm not really familiar with it.
I see. Okay, excellent. Is there an option for thumb ups, Dr. Yasser, and the Zoom? Because also I cannot see that. I can see the chat. If there is nothing, you can respond by the chat. So I will close.
Or you can use thumbs up, Yamana. Okay.
Where is that? Because I couldn't also see it from my side.
Raise hand, maybe you can use.
Yeah. The reactions. If you go to reactions icon.
Anyhow, I will use chatting then. Maybe it's easier. So in the chat, you say yes or no, something like this. So I will ask my question again, and I'm opening the chat. Say yes. No, I don't. Ru'a and Salam. Okay, so some of us did not. Okay, no problem. The others who are aware, who performed and tried this method on his or on her patients? Anybody? You can say yes. Who had the chance to perform this on the patients? People who are aware of it. Sorry?
It seems none of us. We have not practiced it in any way.
No problem. So I can now say whatever I like if nobody knows about anything about it. So nobody will correct me. Anyhow, no problem. You will be aware of the method, and I assume it is a good method. I will not say it is the only or the best, and I will show you why. Okay, let us start. I welcome you all. Just to mention, the sources of my presentation is a book published by or written by Professor Qutbi. He is the founder of this method in Arabic countries, in Arab countries, and also some lectures here and there and the experience. And Professor Qutbi, he saw that he took the information from Sven Smith, the creator also of this method. So the sources are very clear here. Now, in my presentation, I will start by talking about voice therapy as if we are on a height in a plane on a height of 35 feet, 35,000 feet. So we'll see the big picture first from above, and then we go down a little bit, down and down little, we go into details of the accent method. What are the options we have for management of a voice disorder? Assume that you are in your clinic and a patient with a voice problem referred to you for management. So you know that we have the following options. For some cases, we can do voice therapy, if not all. For some cases, they need phonosurgery. Some cases need drugs and some technical aid devices. My question to you, give me an example, please, of a voice problem that needs surgery, phonosurgery, most of the times. You can unmute and speak, and you can write whatever you like.
Polyps? Maybe polyps?
Polyps, I agree. Polyps, most of the time, they need, but not all. So in medicine and in health, take this advice. It is difficult to say always and difficult to say never. So avoid, when you manage a patient, when you talk to the patient and you write a report or discuss a case, avoid using these two terms, never and always. Exceptions are there, but in medicine and in health, we cannot say this regularly. What about drugs? What type of drugs can improve the voice or manage voice cases? Any contribution? You can speak, you can write. Drugs. Can drugs manage voice problems?
Yes, in cases of reflection, reflexes, I mean,
reflux, exactly. Reflux, exactly. Yeah. So I cannot, laryngopharyngeal reflux. Asma, you said GERD, gastroesophageal reflux disease. Currently, when we use this term, we mean problems of reflux affecting the gastroesophageal, the stomach and the esophagus. When something reaching up in the neck, we call it laryngopharyngeal reflux, LPR or LPRD. So LPR or LPRD is the problem or the disease affecting the larynx. And yes, one of the important lines of management of those problems are the drugs. And they are called PPIs or proton pump inhibitors, and they are prescribed by ENT or physicians since they are drugs. But this is one of the lines of management of voice problems in such cases, of course, in addition to anti-reflux advice. Okay, excellent. So today we will talk about one of the methods under the category of the arm or the option of voice therapy, managing voice problems, okay? So now you know where are we in the voice therapy session. So imagine yourself, we are now in a plane, very high height, and we will talk about voice therapy in general. In voice therapy, there are two main parts or two main tasks. I'm sure you are aware of them. Vocal hygiene advice and voice therapy, the sessions. Some combine these two together under voice therapy, and some divide them. So we have the advices to do and not to do, and the therapy sessions. Whether you combine or separate, this is very important. The message here, when I say voice therapy, sessions are planned and conducted. Don't forget this. I like to, in communication problems, when you deal with a patient with communication problems, whether you are a phoniatrician or speech language pathologist or a voice teacher or whatever, always remember this. This is an example I give to my patients and to my students. We have four members in the team managing voice problems, like the four tires of the car, of any car. Without those four, all of them acting actively and participating actively, the problem in communication problems will not be resolved. What do you think those four pillars and or the four members in the management of any communication problem? Four members in the management team. You can speak, you can write.
Speech
I'll tell you the first.
The surgeon.
Of course, exactly. The first one, I would say the first one is the patient, if you allow me. The most important member is the patient, because in communication problems, usually, most of the cases, we don't give drugs, we don't do surgeries. We give advices and we perform therapies. So the patient should be motivated, interested, and perform whatever advice or training he was told to do. So yes, first one is the patient. Second one, I agree, is the therapist, phoniatrician, speech language pathologist, the clinician. What about, who's the third?
The caregiver, maybe?
Yes, the family or the caregiver, of course. Especially if in an old patient or a child. And sometimes also if an adult, like stuttering and whatever. Okay, and the fourth?
I think the environment.
Exactly, the environment, the school, the neighbors, outside the family. So when you manage, this is my advice, when you manage a patient with a communication problem, with any communication problem, think of the four pillars. Putting patient, number one, then yourself, and then the two pillars, usually unfortunately forgotten, the family of the caregiver, not only one, all family members, and the circle, the wider circle outside, including the school and the work and whatever circle is available. So coming back to this, vocal hygiene advice is a very important, essential part that without this, the voice therapy sessions will not succeed. I will put it as straightforward, as simple as this. We have to have both. And why do we need vocal hygiene advice? The advice is to do, not to do, eat this, do not eat this, do not raise your voice, whatever. I said very important. Why? Because we want to create a larynx-friendly environment in the patient, with the patient. We will usually address the diet, lifestyle, vocal demands. Sometimes we should advise the patient that this demand, this high vocal demand you are putting yourself, should be reduced. Accept it, okay? This may affect your work, whatever, but you have to reduce it. So these things should be managed also. You have to know your limits, okay? I don't mean to cripple you or to decrease your limits, but everything has limits. So work on them. Either you expand your limits or respect your limits. And I like the term of vocal finance and vocal fitness. I always say that voice is a treasure. Money, you can say, if you spend it a lot early in your life by shouting, not performing vocal hygiene advice, at your later years, you will not find support for your voice. This is vocal hygiene advice. What about voice therapy? Again, when I say voice therapy, don't forget that the patient is the most important part of the team. He or she should be motivated. Otherwise, voice therapy will not succeed. And I can say this is correct in all managing all other communication problems. And when I say the patient is the most important part or the team member, because at many times you have to tailor the therapy according to the needs of the patient. Not all voice patients are the same. A wife at home, she's not working, is totally different in many aspects from a voice teacher, for example. So tailoring is very important. It's not one size fits all. Very important, before you start, I'm speaking about voice therapy in general. We are still at that very high altitude. We have to make like a deal or a contract with the patient. It is your responsibility to attend the sessions. If you have difficulty in attending the session, don't waste your time and my time. If he is living far away from your place, either he or she can arrange for that, to have housing nearby, to make a session near his place or her place. I do not agree totally with a voice therapy performed once a month. It's not called voice therapy. It's called visit, counseling, voice therapy at least once a week, at least, preferably more. You have to have home practice also, because we are changing your behavior. It is behavioral readjustment. It's not a voice therapy. I mean, it's not like physical therapy, something you do to increase your muscle and then you go home and continue your work. No, it is something you learn in the session and you only perform outside. This is very important. This is essential in all therapy sessions. It is something you perform outside this clinic, this session. So you'll be given home practice and you have, can you do that? You said, no, I cannot, so don't waste my time. And we are preparing you to carry over those functions, those behaviors you are trained on in the session to do it outside. Otherwise, it's useless. I advise to give some general education of the patient, because motivation is important. One of the big supports of motivation is for the patient to understand, why should I do voice therapy? So some basic anatomy. So I assume you have some diagrams like this, if you can see, simple things like this to explain, or diagrams like the one you see here, to explain the basic things. This is the larynx, this is the vocal folds, whatever is happening here. So some basic advice is very important. Speak basics of physiology, how to produce voice. And the more the patient is voice professional, the more details you give. Again, you have to tailor the information according to the patient need, of course. If he's well educated, more information a little bit. If he or she layman or laywoman, so the basics things, very, very important also. And give him or her basic realistic expectations. You are a teacher, so our aim is to help you to perform your teaching without much of a problem, not to be a singer. If he's a singer, okay, we will try our best to get rid of the vocal nodules to improve your performance in singing, whatever. So expectations and the limits are very important also. Okay, what are the voice therapy options we have? Still, we are in the high altitude. There are many classifications. Either there are specific methods for specific problems, or diverse methods, or the holistic. And I will explain what holistic means. Specific means specific problem, specific method. For example, there was a problem, there was a technique, and I say was because I don't encourage you to perform this technique. It's called pushing technique. Who knows what is pushing technique?
It's used for vocal fold paralysis.
Uh-huh.
Yes.
And how is it performed?
You're supposed to push
something
on a table or something to try and adapt the vocal folds.
Exactly, which is something you should avoid, because when you ask the patient to say, when you're pushing the wall or lifting your hands on a chair like this, this will increase compensatory vocal techniques. I mean, the false vocal folds, and this will not help the voice. So I advise you not to use this method. The other method we call is invitational dysphonia, the finger manipulation or the pressure, the specific method for that. What is mutational dysphonia? Incomplete mutation, also the same name. What is it? What is this problem? Assume you have a patient coming to you, usually a male. He's 15 years old, coming to the clinic and he's speaking in diplophonia. Sometimes he has a big voice and sometimes he's having this fine and a high-pitched voice. Diplophonic patient, a male, at puberty, he cannot perform, he cannot prophonate with his low pitch and still having some high pitch. This is called incomplete mutation. That adult patient, male, could not acquire the low pitch of the adulthood and still maintaining both. It's called incomplete mutation. Those patients will benefit from the finger manipulation. I don't have time to explain that. You can of course you can see some sources about this, but it's some manual therapy. This is effective and you can do that, no problem. In psychogenic aphonia, some patients may lose their voices because of some psychological trauma. Psychogenic aphonia or hysterical, this is, I don't like this term. I like psychological or psychogenic. The techniques used for those patients very specific, using humming, coughing, whatever, they are okay. So these are specific methods. Diverse methods, many other methods, relaxation, pitch inflation, yawn sigh, whatever. Not bad, but they are very diverse. I assume they are weak. They are not holistic. Holistic methods are methods, voice therapy methods that tackle, manage, respiration, phonation, and articulation. Not only phonation. One of them is the Smith accent method. We will talk about it today. And I will show you why accent method is a holistic method. It's only one. There are other methods which are holistic, but myself, I have training on accent method, so I can talk about this freely. Again, general talks. What are the indications of voice therapy? A voice patient, you can advise or is fit for voice therapy or not? It's a big question, a very important question. I can say that voice therapy is the main part of the therapy in some conditions. Non-organic voice disorders. Give me an example of these non-organic voice disorders.
Hyperfunctional dysphonia.
Okay. What else?
Also, I believe the mutational one that you mentioned.
Okay, you can. When I say organic, I mean there is something organic is there. Carcinoma. I can put here benign vocal fold lesions, but it's better not to put that. The organic lesions, there's paralysis, sulcus clear, and carcinoma. So non-organic, there is nothing clear. Hyperfunctional, phonosthenia, whatever. Some benign lesions, benign vocal fold lesions. Example of benign vocal fold lesion, where the voice therapy is the main therapy line.
Nodules.
Nodules, of course. Vocal fold nodules. We said polyps, surgical, cysts. If they are diagnosed, if the patient is clearly diagnosed as cysts, voice therapy is an option, but I will not say the mainstream option. Usually cysts need surgery, usually. I can start voice therapy, but my question clear, what is the main line of management? Nodules, yes. Cysts, yes or no. Some organic lesions. Give me an example of an organic lesion that I should perform voice therapy as the first option. Still organic. There is a lesion.
Nodules, maybe?
Nodules, some say it's organic, some say it is something in between. Other than nodules, I will tell you, vocal fold paralysis is very small glottal gap. Or vocal fold paralysis is an organic problem, of course. But if there is small gap, some studies say 1 millimeter, but you can use it for 2 or more. If there is very small glottal gap and the patient wants to improve the voice therapy is the first line, not surgery. So an example of organic lesion with the voice therapy, the main line of management is vocal fold, unilateral, true vocal fold, paralysis with minimal or small glottal gap. Of course, voice therapy can be used as an addition, as complementary with other lesions, with other lines, like with drugs, like reflux problems, and for surgery, of course. There is a cyst, there is polyps, removed by surgery, so you can advise the patient to have voice therapy before the surgery and after the surgery. Why I need voice therapy, even if it is complementary, it is something additive, because it will help us, help the patient to get rid of the predisposing vocal habits, like shouting. Take this example. Patient came to you, referred to you by ENT or phoniatrician to do voice therapy. He was a case, or she was a case of vocal fold polyp. Okay, it was small polyp. Let's assume it was a big polyp, and it was removed by surgery. The glottis is fine, but he was referred to you for voice therapy. You can examine if you are trained to do that, and you will not see any mass. What's the role of voice therapy in a patient who had surgery and his vocal fold polyp was removed? This is a question.
To prevent recurrence, right?
Of course.
Because, yes.
Yes, because there was a faulty habit for that patient that produced the vocal nodules, the polyps. So in voice therapy will help the patient to get rid of those, to be acquainted that you are predisposed to have polyps again, so the voice therapy can help. This is very important. And to adjust his new voice in a maximum way. Also, this video before, it was viral in the internet and Twitter. Do you know what is this? This is MRI, magnetic resonance imaging with high speed, we can say, real life, real time. You can see now how the patient, the human being, the structures inside when the patient talks. He's talking German, by the way. You see, subhanallah, how the tongue is moving during the speech, the lips, soft palate, you can open and close, open in some vowels, close in some other, most of the vowels, and here the area of the vocal folds. You see, closing and opening. During breathing, they open to take air. During phonation, they close. See coordination, subhanallah, between those articulators and the vocal folds. There's a process of phonation is here, the process of speech or articulation is here, and of course breathing and the control of the language. Fantastic, subhanallah. I'm trying to arrange a study like this in Arabic. I hope we can do something like this to see how it looks like the tongue and soft palate and whatever during Arabic speaking. Okay, now 35, we will go a little bit down. We will speak about accent method of voice therapy. And when we speak about accent method, we have to also mention the name of Smith, because the method is called Smith accent method. Smith is the name of this guy, Danish professor, who created this method. And the accent, because this technique depends on the accents, I will explain this in a while. What are the indications of the accent method? Again, speaking about the indications of voice therapy, the same thing I mentioned before, but there's some more details when I speak about accent method. Of course, voice problems. But do you know that accent method was used in some speech problems like dysarthria and stuttering? You see now it is holistic. Holistic because it manages voice and tackles speech. So in some studies and some countries, some centers, they may use this for dysarthrophonia. Dysarthria, when with voice affection, dysarthrophonia, or in stuttering, not a common method in managing stuttering, but since breathing is an essential part of the accent method, it can be used to control breath control. It can be used in language, by the way. Do you know why? The prosody issue. The prosody, the tone of speech. Accent method is good in that also. But the main indication is voice. Now, this is a very important slide. This is like a definition of accent method. When I say what is accent, the essential parts of components of accent method, this is the accent method. Accent method, by definition, is integration, dynamic integration of two parts: breathing, abdominal diaphragmatic, physiological, and rhythmic, accentuated accents are there, نبرات مختلفة, accents, rhythms, vowel play, and phonation, and in speech. So this is the definition. The integration of these two things. I know that body and arm movements are part of it in books, but myself, in my training and my practice, I do not perform body parts because more in dancing. So in my practice, I concentrate on these two. Okay. Again, breathing, phonation, speech with accents and rhythmic vowel play. I will go into details about this in a while. Why holistic? Again, I think maybe you can answer that. And the accent method technique and training, I do not give, or the clinician, the physician, do not give a separate attention to tension, pitch, and loudness. Usually, they manage it collectively. But of course, if there is a clear problem in tension, I will give this more concentration. If there is a clear problem in pitch, I will give it a priority. But it is usually not separate attention about all of these. And also, simultaneously, I will manage and tackle respiration, phonation, and speech. And I will show you how. Work, it is strength, hyperfunction. If there is a patient having clear hyperfunction, or even moderate or even mild hyperfunction, vocal hyperfunction, accent method is good. If there is muscle tension, accent method is good. If you want to improve the aerodynamics in breathing, accent method is also good. This is the second important, most important slide. What are the parts, stages, we can say, in accent method? We have 4, but again, I will speak about the 3 main here, and I will not talk about the movement exercises. This is more to people performing, dancing, and walking and on the stage. Usually, we don't need it. So I will talk about the 3 main parts. Stages, we can say, stages. I have to go into explanation, and I will take what to explain what, and then the foundation about breathing. Then we'll go into phonation. So explanation, breathing, and phonation. So bear with me. These are the stages. Now you are trained to do voice therapy using accent method, ready for that, and you have your patient. The first thing you do with the patient, as I told you, is the explanation. Why? Because again and again, patient is the most important member of the management team. First, I advise you to speak about voice therapy. Why we should give you voice therapy. You have such and such problem. We were diagnosed with vocal fold nodules. And this is because the nodules, those small things, bilateral symmetrical things, because of the shouting, you are performing on your kids. I suppose she is the female house or teacher. So we will talk about voice therapy. Voice therapy is a technique, some kind of a technique. I will train you on that. And you talk about why do you use voice therapy, recurrence, whatever. And essential part of this technique will be breathing. We will give you training on breathing. Expect a response here. She will say, breathing, doctor, or whatever. I don't have a breathing problem. My breathing is okay. My problem is phonation. Why should I have breathing exercises? I don't have time to come to you once a week, like you told me, and you are training on breathing. Breathing, no problem. So you should explain. See, you have, when you speak, you have to have air. You have to have air in, and you exhale. Your voice is produced when you exhale. So breathing is very important. Look at it like it is the gas for the car. Air is the power for the larynx to produce the voice. So breathing is very important. And then you talk to her, you say, part of the breathing, we will train you on abdominal breathing. Abdomen, she will tell you. Abdomen, come on, the problem in the neck. You are mixing things. I have no problem in my abdomen. It is here, the voice. I feel tension. I lose my voice. Why should I have problem training with the abdomen? Again, it is essential. Your answer will be abdominal breathing is the type of breathing which is physiologic. Breathing is very important. It should be through abdominal breathing because you can control by your abdomen. You can control expiration. You can produce more air, and air, as we agreed, is very important for phonation. And you have tension here in the neck. I don't want you to have tension here, but it's not a big problem to have tension in the abdomen. And this will give you more relaxation when you use your abdomen. In addition, it is more physiologic. The tension in the neck will be reduced. So no problem. Believe it or not, when I train you on abdominal breathing, you will feel relaxed in the neck. And sorry, let me move this. And you may, at this stage, this is what I usually do to prepare the patient, that during this session, these sessions, we will play with vowels. I will give you some exercises in this session to play with vowels, I, E, U. You may feel it is strange, but it's very important. Why vowels? I look at it like they are the alphabet letters. Alif, Ba, Ta, or A, B, C. You learn about them separately, and then you put them into a word. So here in voice therapy, I will train you on A or E and U, and then this is a preliminary stage, and then you will go into words. This stage is very important because you will sometimes, some patients feel awkward when they enter this stage, or funny. So you have to prepare them. Now, explanation. Any question? Sometimes I spend the first session, the whole first session, in explanation and answering questions. It's not a waste of time, because without proper understanding, he will not or she will not be motivated. Expect the patient will have some doubts after the first session, and he or she will think, is this clinician aware of the voice therapy and experience? So he should be motivated, and a trust should be there. So do not give extra information, not more, not less, and be sure he or she will come again to your next session. The second stage is breathing. So we discussed before the first session, we will spend one session or two in breathing, and you explain to him or to her why breathing is important. I advise you in the second session, you repeat yourself, speak about the importance of breathing. You can use diagrams. You can show him yourself how breathing incorporates itself into phonation. You have breathing, you have phonation to talk. So this is very important. Question: what's the difference between A and B? This breathing, A and B, are also a mode of the breathing. What's the difference between A and B?
Maybe it's the abdominal.
Okay. The second voice I heard, you can continue. Unfortunately, I can't know the names. The B, what is the B?
So
It could be clavicular or costal.
This is breathing during phonation. This is breathing during rest. You take in, silence, in, out, silence. Though during relaxation, you are breathing using this method when you are listening to me. I am breathing using this method when I speak. To speak, I have to take good big inhalation, and then I distribute my air throughout my sentence. This is very important. So for proper breathing during phonation, the patient has to have good amount of air, and he or she should be trained to exhale that air quietly during phonation for a longer period. Not like this. Both are very important, and both we perform these. This is the breathing we will train the patient on. We can start accent method for breathing during lying or standing or sitting. These are for difficult patients. When I tell you they use abdominal breathing to show him what is abdominal breathing. Abdominal breathing simply means I will train the patient. If you can see me, I will ask the patient during sitting. That's why I advise a female will train a female patient and a male patient. Sometimes I need to put my hand on the abdomen. Sometimes, not all cases, if the patient does not understand. So I explain to the patient, I need you to have good air inside. Imagine your abdomen like a balloon. When you take air, I need you to expand your abdomen. We know that air doesn't go into the abdomen, but there is something called diaphragm. When you take air, it expands, and imagine the abdomen should be inflated as if it is a balloon. So during inhalation, the abdomen should be up and expanded. During expiration, should go down. You have to spend sometimes one session, sometimes 2 sessions on that. It is essential. Without performing good abdominal breathing, do not go to phonation stage. So simply, and you can repeat that again. It is not easy, by the way. You can do also, ask the patient to put one hand on the chest, one hand on the abdomen, and ask the patient to take in air. A question to you. When I put my hand here and one hand on the abdomen, and I take in air, inhale, what hand should go up or expand?
The lower.
The one.
Sorry, the lower, of course. Yes, exactly. So here should be relaxed. I don't want any movement here. This is not good. This is creating tension. I need abdominal breathing. It's not easy. Can you do it on yourselves now? Can I ask you, all of you now, to put a hand on the chest, another hand on your abdomens, and then relax, and then take air, mouth and nose, no problem. Take air. At the same time, expand your abdomen. And when you exhale, press on, contract your abdomen. Go inside, the maximum inside. Remember the B graph. So the maximum up, forward during inhalation, maximum inside during exhalation. We need this good range of abdominal movement. If the patient is fatty with a big abdomen, it is difficult to perform this. If she is pregnant, it is difficult to perform this. If there is a weak abdominal muscles, usually it is difficult or suboptimal. So do it again. Hand of the chest, hand of the abdomen, the lower hand of the abdomen, then take in air. What should move forward? Which hand? The lower hand. And then exhale. This is very important. Sometimes, again, I perform this for whole 1 session or even 2 sessions. If it was difficult, and it is difficult, by the way, for most of the patients, put a book on the abdomen to see the movement, to appreciate that movement, or put a hand on the abdomen. When you take in air, again, imagine, tell the patient, it's like a balloon. It is like a balloon. So in air expands, out inside. This movement should be very clear and coordinated. During breathing, now no phonation yet, breathing. If you think at the stage that she or he is controlling this nicely, more than 90% of cases, I assume 100%, you can go to the second stage, which is phonation. So breathing is okay, and remind him or her always during breathing, and of course, more concentration, more reminding on the phonation stage. Everything here above the shoulders and above should be relaxed. No tension. I don't need you to use any extra laryngeal muscles during breathing or phonation. Not needed. Only the true vocal folds should move in and out. Of course, some extra laryngeal muscles here and there will work, expected, but not the gross ones. Patients, sometimes they forget about it. They are unaware that they are using muscles here during phonation, especially the hyperfunction. So keep your eyes on the neck and the shoulders during breathing. Very important. That's why I spend 1 or 2 sessions on that. Should be relaxed, all the abdominal side, abdominal breathing only. Phonation. The phonation exercises has 8 stages, sub-stages. We said breathing, phonation. In phonation, there are 8 stages, very practical stages, easy to be memorized. And you can start, you can recognize now, we are training the patient on simpler, going from simple practices, exercises to more complicated. First, on training on phonemes, voiceless and then voiced. Then vowels, I, U. This is the stage of the vowel play. We discussed it with the patient before. And then words, then sentences, more than 1 word. Then during reading, then monologue. Monologue, I mean, speak about yourself. I ask an open-ended question. What did you do last summer? What's your job? Let him or her speak for a few minutes. Dialogue, it's more difficult, answering questions. Ask question and answer. And then professional activity, you can train in this session. If he's a teacher, let him stand, and you are a student, and let him or her speak in front of students like in a class. If he is imam in prayer, let him perform Fatiha in this session. And of course, outside, and to come back to you and give you the impression. So these are the stages. The general rule, go from one to the next, at least 80% successfully, better more, doing that the session. I think it's very clear. Simpler to more complicated. Again, you have to monitor breathing. Breathing is essential in all stages. What's difference? What is the main problem? Sorry, the main giving accent method. It's peculiarity. It is rhythmic. You remember, accentuated rhythmic place. There are some rhythms, and this is very peculiar to accent method. Rhythms are some kind of music, okay, but without instruments. This is a method for the patient to perform, preparing her or him to have some training on that, because it's simple, to be used in speech. In all stages I mentioned, phonemes, vowels, words, whatever, I will use those rhythms, especially in this stage, on these 1 and 2 stages. And of course in words, but the rhythms you have to use in 1 and 2. What are those rhythms? The first rhythm we call the largo. some musical term. This is the accent method philosophy. Largo is a rhythm like this. Hey, 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 hey. Largo. Hey, hey. Ah. What is the and largo? Largo, you can again put the hand on the abdomen and tell the patient that you will perform a accent nabra. You will say a small push and then a why? You are training him or her on using the abdominal muscle like the pedal of the car. When you want to go fast, you press fast, you press hard on the pedal for the engine to give more petrol, more air. Hey. This is the way when I ask the patient to raise the voice, not to make tension here. No, use the abdomen. Hey, like this. So you are diverting tension from here, from the neck, from the muscles of the shoulder to the abdomen. Abdominal tension is healthy, non-traumatizing. Hey. This is called largo. More complicated thing is andante. Hey. So two. Hey. Two pushes and one more. Again, this stage can be looking funny, especially to non-professional voice users, non-musicians, non-singers, imams and prayers. What is this nonsense? Again, you have to explain. This is why we spend some time in explanation. This is very important. Now I'm training you on simple tasks to control your abdomen. If you cannot, this is a very important message. If the patient cannot control his abdominal muscles, those presses, those accents, he will lose the power of accent method and the power of abdominal breathing. It's not one push like this. It should be accentuated with the accents of the speech. This will give him more, like, again, when you drive your car, you do not push the benzene, the petrol pedal the whole through during the whole trip. You sometimes put little bits or sometimes more. Sometimes you put your leg out of the pedal. This is the normal. So this is the pedal of your speech. Allegro, it is more prolonged. Hey. And you can, maybe you heard me knocking on the table. This will ease training. So I'll tell the patient, Largo, be with me. I will do the job, the task, and you echo me, after me. And this is a bing bong play. Also the beauty of accent method, that I do the in front of the patient. When I finish, he or she should do it and then come back to me. So I will say, hey, and he or she should respond to me, hey. I will say, and then bing bong play. During this, he should imitate me. He or she imitates me and do the same. And sometimes I increase my voice, reduce my voice, increase the pressure. So he has this flexibility of the movement. Largo, andante, and allegro. And then maybe remember, I told you I have to use first voiceless. Start with simple. Then voiced. Still the voiceless. Step by step. If you're controlling this nicely, I will go to vowels. Forget about this. I will start from here. E. Again, I cannot go into details because this needs a workshop, completed workshop, but there should be no interruption. It's not like E and then take breath and E. No, it is a continuous action. E, no stopping. Why ha sound? In some hyperfunctional voices, it's good to start with ha. Hey, he, or hey, ha, to reduce the vocal attack. or glottal attack. What is glottal attack? Glottal attack.
Is the vocal fold closure when it goes
Sorry
like,
again. Sorry again.
It's when the vocal fold closes in an attack, like in a very hard way, or
Glottal attack, I agree with you partially. Glottal attack can be normal or abnormal. Glottal attack is, I agree with you when you say when you start the onset of phonation, the vocal folds like this, open during breathing. During phonation, the start of phonation, they come together and then mucosal waves. This coming together at the onset, start of phonation is called glottal attack. Some have soft glottal attack, they do not touch, and some hard glottal attack. A, ah, oh. So it can be hard, it can be soft. The normal is the middle, normal glottal attack. So if the patient having hard glottal attack, a, ah, no, avoid this ah, hey, anyhow. So remember, again, vowels, hey, whatever, largo andante, largo, allegro andante, and then we go to vowels. He's okay, she's okay. Then I will go to words and other stages using this. Words like Bismillah, Wahed. Always again, to take breath, hey, and then as vowels, then words, Wahed, by syllables. Divide the words into syllables. Each syllable is a one push. Wahed. Not like this is abdomen, huh? Not like this. Wahed. No. Wahed. So continue. There's a continuation. It's a continuum. Again, it needs more practice. Now this I'm giving you a general idea. When I speak about stabilization, it's very important. This is for every technique. In voice therapy, in speech therapy, in language therapy, but in voice therapy is very important. I have to stabilize the new acquired voice. It can be stabilized by, in fact, method using different rhythms, largo and andante. The variation, difficulty, and loudness is very important. Loudness, pitch, prosody, sometimes posture, standing, sitting. Stabilization is very important stage. Some put it at, where that stages, slide of stages. Some put it here, stabilization. Explanation, breathing, phonation, and then stabilization. Stabilization can be included in phonation or separate, but because it's very important, I consider it as part of phonation. Because we are talking about voice therapy, we have to train the patient to how to stabilize the newly acquired voice. One also home program. At all stages, again, at all stages in the therapy, and you train the patient on that also, he and you yourself should be attentive to posture during therapy. You should be sitting relaxed, standing relaxed. Put an eye on this. Train him or her to think about this and to look at this. Maybe during, putting a mirror to monitor the posture. Also, it is very important, almost always forgotten or neglected, the articulators. Again, this holistic method. Train the patient when he or she speaks, even for phonation. I'm now managing phonation, I know, but he or she should open mouth. Freely. Phonating like this will reduce the elasticity here and will make the phonation more tense. Train the patient to move freely. And usually I tell my patients, look at news readers, okay, newscasters, and then TV. Reduce the voice and look at them, especially the American news readers. They open the mouth freely during speech. I like this. So this freedom is very important, articulators. And also hear and monitor the pharyngeal involvement in phonation. Like this, sound. When you hear this sound during phonation, that means he's using the pharynx during phonation. this will cause voice fatigue and this tension. The voice the pharynx should be wide. See now, observe the difference. I'm now speaking with wide pharynx. 1 2 3 4. Now with wide pharynx. Now with tense larynx. 1 2 3. This tension is at the laryngeal, not at the at pharyngeal level, not at the larynx. 1 2. Avoid. This should be avoided. Even a mild degree of it. You see, holistic. Monitoring is very important. Again, you have to monitor the patient. Self-monitoring is even more important. Advise the patient always to monitor. How? When you hear or observe something not good, not performance, a bad performance, stop and ask the patient, did you notice anything abnormal, not good, in your voice, in your position, in your pharynx? Give him a moment to think about it. If he doesn't feel it, this is a problem. Repeat it again, let him monitor that. Again, this is an all voice therapy sessions. You have to train the patient to be self-monitoring, not dependent on you. And also the therapist. Intonation, always observe the attack. It should be to the softer side. Assalamu alaikum wa rahmatullahi wa barakatuh. No, stop. You are performing nice, but there is a small problem. When you start your phonation, the onset, there is sound. Did you notice that? No, I did not notice. No, please. Hear your voice. I can record your voice and hear it. You should avoid this. And the pitch should be optimal to the age, to the sex, and avoiding fry. What is vocal fry? Vocal fry. One of the registers.
Using the posterior.
Give me an example. Can you perform this to me? Give me how does it vocal fry is produced?
Good morning.
Like this. If you can hear me at the end of the sound. Yeah, I can be with you. This is vocal fry. This is not a good technique. Should be avoided. One of the registers that should be avoided. It's called fry. It's like frying eggs. That popping sound. It's not good. So no thermal fry at the end. Also observe articulation. This is a very important point. Very important point. Avoid speaking on residual air. In accent method and all methods. I told you the patient, Miss Nora, in the first session, that air is very important, like benzene to me, like oil, like petrol to me. No air, no phonation. This is the rule. No air, no phonation. Do not speak, do not produce sound without air. What's happening usually, they take little amount of air and produce a very long, excited sentence. No air. السلام عليكم ورحمة الله وبركاته. كيف حالكم؟ مساكم طيبين. والله إن شاء الله إحنا ماشيين معكم إن شاء الله. Why is that? Why? Stop. Do not speak with any even residual air. Divide your sentences and have good breathing, good air, good amount of air before every sentence. So avoid this. You have to monitor this, your information. You have to monitor articulation, self and therapist. There should be those accents. Assalamu alaikum, wahid, ithnain, with intonation. And phrasing with pauses. Stop when there is no air. Divide your speech, your phonation into sentences, small sentences, and take breath in between sentences. Very important. And the rate also you monitor it. You see how holistic this method is? The challenge, it's not an easy step, by the way. This monitoring business is not an easy thing. Why? Because most of us, normal people, in their life, we concentrate on what to say. Those patients, even yourself, by the way, when you feel a voice problem, you have to concentrate on what and how, both what and how to say. By the way, a question. How many of you is having phonesthesia? Do you know what is phonesthesia? It's voice fatigue. How many of you feel voice fatigue after talking for prolonged periods? On phone, lectures, whatever. How many of you? All of you, Lujain, I don't know. I'm one of them. I have phonesthesia, if not controlling myself. I think most of us, when we speak and phonate for long periods, of course, there are limits. Even normal people, beyond those limits, we should be fatigued. This is normal. But a lecture of 1 hour or session for 1 day, we should not bring us into the whole of the depth of phonesthesia, especially if we are performing abdominal breathing. So it is those what I'm talking about is also, by the way, important to us as professional voice users. Now I finished talking about the technique itself. There are practical applications from my experience, from Dr. Prof. Qutbi's experience, and voice therapy in general, and an accent method. So those are practical points. Always in the room, make sure that it is very low ambient noise, I mean the therapy room, and acoustically treated. Outside, what about at home? Especially those with phonesthesia, but for everybody, avoid speaking or phonating in a room with background noise. I always tell my daughters, my sons, when I'm with them in the living room, please reduce the TV if you want me to speak with you. I cannot speak with the loud voice or sound of the TV or somebody is shouting, because unconsciously we tend to increase our voices. So always prepare, make yourself, allow yourself to speak, to phonate only in a low background noise. During the session should be reassuring. Do not stop him. Sometimes I say stop, stop, just to tell you. But during the session, do not use the words more than stop, stop, what is this? You are doing bad. No, the session should be reassuring. You did this part nice, but this part we should improve it. And again, the air conditioning, whatever should be okay. Position of the patient. Sometimes we need to start on recumbent, but most of my patients can during sitting, no problem. What aids I use in the writing of the session of the accent method, say sometimes use drums. I'm telling you, no need for that. Finger or a pen, or you clicking like knocking on the table. This will help on the patient for the rhythms. You use this in the rhythms. Largo, andante, and allegro. And you ask the patient to go with the rhythm. Again, this is a stage to increase the control for abdominal muscles. Recording is a good way. Record the patient and let her or him hear the problems in her voice and to improve it. Also at home. It can be done as individual therapy, and this is maybe a surprise, but it can be done as group therapy, but should be homogeneous group. The session is usually about 20 minutes or more. And as I said, once a week minimum, better twice a week, maybe twice a day if intensive. For example, patient coming to you from outside your city and he or she will stay only for a few days, you can give twice sessions per day. The ping pong play is very advantageous step. And like I told you, I will tell my patient, I will perform something, and you do the same. Hey, he or she will say, hey, and observe. واحد, Bismillah, Bismillah. Oh, I tell him, oh, did you take enough air before saying Bismillah? No. Let us repeat it again. Take breath. When I perform my part, please take breath and be ready. When I finish, you start. So you see this economy of time. I do it, then you do it. When I do it, he observes me. And sometimes I do something wrong, and I ask him or her, what is the wrong? What did I wrong? Wrong practice. Correct my performance. So he will be to increase his self-monitoring. He will tell me, oh, this is more than needed. Reduce it. Thank you very much. Excellent. You see, this ping pong play is nice. And try to correct one thing at a time. If you feel the patient having 3-4 problems at the same time, you can tell him, but try to solve and train him on once. I know it's a holistic method, but in some patients, they cannot correct everything at one time. At that stage, you see this sound will concentrate during this session on the onset, reduce it, and train him on that. And then, as I told you, escalate in difficulty. Voice therapy in general, it's not only for accent method, voice therapy in general. You will face rigid patients. Rigid, that means they will not improve nicely, or the voice therapy will not benefit them at all. Voice therapy is not a magic thing. It's not one size fits all. It's not the silver bullet. It is a method that can benefit many patients, but not all patients. And as you remember from my slide and presentation earlier today, that I told you there are some indications. Carcinoma, big lesion, ugly lesion, big polyp. It's not a voice therapy business. You can start pre-op voice therapy, yes, no problem. Just prepare him for post-op voice therapy, but it's not the main line of management. There are rigid patients that you expect them to have to struggle with voice therapy. Old patients, they are expected to be difficult patients. Why? Because of the age and because of the difficulty in controlling abdominal muscles. Okay, and they are used to that method for many, many years. This is very important. Patients who are perfectionists and professional voice users, maybe of this time, they want everything to be very good. Excellent. Very good is not enough for them. Excellent. He or she should perform singing like the best singer in the world without any problem. It's not happening. Even famous singers, they have problems. Even famous performers, they have problems with their voice. They have to rest. So perfectionists are difficult to manage. And dysarthrophonia, if there is neurological element. Dysarthria, as you know, it is a speech problem. If there is a phonation component, vocal fold paralysis or tension, those are difficult patients. And of course, unmotivated patients. For me, it happened 1 or 2 times in my career that I told my patient, sorry, I cannot continue with you. You are not motivated. And we discussed this 1 or 2 sessions. He was feeling he's wasting the time. He wants something quick. I told him, no, we cannot do it. I'm training you to perform nicely during your phonation. It is your job to do that. It's not a medication I give you, it's not surgery. So motivation is very important. And of course, hearing impairment. Patience, because it is a ping pong play. I cannot shout the whole session. It will destroy my voice. And unless he's having hearing aid, whatever, but difficulty in hearing will make things difficult. How many sessions? Usually 6 to 8, maximum 10, sometimes 20, but most of them are maintenance. So usually I give on average 6 weekly. And then after finishing those, when I feel that he's reached the stage of professional, he told me and I will talk about now how when to terminate. So when there's, I said it's not enough for weekly sessions, I may give him or her a monthly session, not to make sure everything is going smooth. But at least 6, maybe. I seldom I manage to reach my goals in less than 6 or 4. Let's say 4 to 6. When to terminate? If the patient said, and during real life, I'm fine. I'm a teacher. Now, alhamdulillah, during giving my lectures in school, alhamdulillah, my voice is fine now. Okay, now we can terminate and give follow-up only for maintenance. If the upper is good, what is upper? APA. Did you hear this voice before? This term before, sorry. No. Auditory perceptual assessment. Auditory perceptual assessment. So upper is my evaluation of his or her voice. When he or she was like this, phonation, and then during this, after the sessions, it's more relaxed and normal. So my auditory perceptual assessment, there's improvement. It's good now. Now we are fine. Or if the glottal picture, I send him, or if I'm trained to do, I do the endoscopy, and the nodule disappeared, congestion disappeared, hyperfunction disappeared, the glottal gap and vocal fold paralysis improved. There is good motion of the glottal wave. I said, okay, now we are done. But again, maintenance. Remember, when I terminate the session, this does not mean that he or she will terminate the training, will terminate the practice. It's not physiotherapy. You have to repeat that many times with the patient. It's not sessions, something you do and you strengthen your muscle in the session and don't forget about it outside. No, it's something you are trained to do it nicely here in the clinic, and then you continue using that. So abdominal muscles, abdominal breathing, you have to perform this during your whole life, preferably during even talking with your friends, at least during the vocal demanding talks, like lectures, singing, whatever. But the more, the better, because to be part of your life. Is accent method effective? Yes, there are many studies. These are examples. You have those in your video. And yes, it proved, it was studied, it is effective. And myself, I'm using accent method on myself, by the way, especially when I feel my phonesthesia is troubling me and I have a voice, I have a talk, I use my accent method during talking. And by the way, if you are training the patient nicely, you will not, the attendants will not notice that the patient is using abdominal breathing. By the way, now I'm talking to you with abdominal breathing. Now my abdomen is pushing, and I take breath, extend my abdomen forward, and then during my talk with the syllables, I do my pushes, my accents. This will make phonations much better. Of course, with frequent training, this will be more natural, and this is the importance of training. So to wrap up, there are 2 or 3 slides. I will repeat them with you. The first slide is not here. If you remember, what is accent method? It is abdominal breathing plus rhythmic accentuated vowel play, phonation, and speech. Movements, part of it, but I do not perform these. What are the stages? First, explanation. It can take 1 or 2 sessions. Usually 1 is enough. And then breathing. When I say breathing, abdominal breathing, lying, sitting, whatever. This is the foundation. Controlled nicely. Then I will go to phonation. And the phonation, the stages I told you about. I start with phonemes, voice, voiceless, then vowels, vowel play. He's okay or she's okay. واحد. السلام عليكم ورحمة الله. يقرأ قرآن. Reading Quran. قل هو الله أحد. Allahu Samad. I usually use my hand to remind him or her with abdominal muscles. Because this is the patient and this is the abdominal muscles. Alhamdulillahi Rabbil Alameen. Maybe he cannot do this for long sentence. Alhamdulillah Rabbil Alameen. And so on. So this is abdomen should be moving, not one push. Ideally, take in breath like this and then in pushes. Sentences, then reading. Now read the sentence, and I usually put mark for sentences where to stop and read and take breath, and then monologue, and then dialogue, and then ask him or her to stand in front of me to teach, to give a talk, to read Quran, whatever, to make sure he's okay or she's okay, and ask him or her to perform this during real life, and come back to me and give me what were your problems. This is very important. Like I told you, the stabilization stage. And I remind you what is used in accent method, not in other methods. Largo. واحد اثنين andante and allegro and so on. Again, you can play with these. Aim is to train the patient to have this control. The more control he or she is having on the abdomen, like the pedal of the gasoline in the car, the more natural. And when this movement is there, the abdominal wall, this is the proper abdominal breathing, you will shift tension from the neck to the abdomen. Relaxed up and do the tension here in the abdomen. This is a training, very important. Thank you very much. If you have any question before ending my presentation, I will be happy to answer. You can write and you can talk. Thank you again.
Thank you so much, wallahi, Professor Khalid. Yani, it's always great to have you. طيب, بنات, any questions?
It was very clear, Doctor. Thank you so much.
Thank you, Doctor. It was really informative. Thank you so much. We appreciate it.
يعطيكم العافية. مثل لاحظتوا أنا I talked about accent method, but I give more time, you can maybe notice, on voice therapy in general. Those concepts I mentioned to you is practical, and it's all involving nearly all types of voice therapy, and I assume all types of therapy in your life. Again, I should also repeat myself, don't forget the 4 tires of the car, the 4 main members of the therapy team. First one is the patient. He or she should be motivated, attentive, like a contract. I like to use this term. It's a contract between us. Second is yourself. Be motivated, of course, with the patient, attentive during the session, and showing your care and interest. If you are not interested, the patient will not be interested. Third is the family members. Sometimes you need to involve them in voice therapy, in speech therapy, in language therapy, especially in language therapy. And the environment. Sometimes you need to visit the area or contact the teacher at school, or at least to send a brochure to him or to them there. It's very important.
Professor
I have
Khalid,
a question.
Yes.
In the accent therapy, do you do like any kind of warming up before in the initial starting the session, like for example some kind of massage or like any warming up exercise, or you just start with the teaching the abdominal breathing?
Okay, it's a good question. It's not an integral part. Warming, vocal warming, is not essential or integral part of accent method, but it can be used, of course. And especially in professional voice users or singers. I sometimes use that, especially again when I feel he or she is not very well prepared, coming to me right after awakening from sleep or very early in the morning. Yes, I ask them to do some thrilling or to go up and down. But if you remember, and during my sessions, we start gradual. So even for session number 4, I repeat what I did with him or her in session number 3, last session, and start with breathing, phonation, simple tasks, and then go into big tasks. So answering your question, yes. What about massaging? No, it's not integral, it's not part. Neck massage, whatever, is not part of it, but I'm not against it, especially if the patient is pinpointing to the localized tender point in the neck during phonation. It can happen in some phonesthesia. If he or she is pinpointing that when I talk, I feel pain or tenderness here, or usually, not usually, some patients use themselves, they localize a tenderness. In those cases, yes, I may ask him or her to do some massage, because again, it is muscles, the movement of the phonation is air, yes, but the larynx is, don't forget, they are larynx is composed of cartilages connected by joints, moved by muscles, lined by membranes. So sometimes it's some kind of local tenderness is there. Yes, at these cases, some massage of that area is okay. It can help, but it's not essential part, integral part of the accent.
Professor Khalid, can I ask this question?
Of course.
الآن احنا we notice with the accent method and you start with the voiceless sounds, if, is, ish, it, etc., and then you move on lil voice. However, with other physiological therapy approaches like resonance voice therapy, حتى vocal function exercises, إنه احنا عادة في resonance, for example, the first 4 stages you only work with the voiced consonants. The other thing إنه احنا we know that with the voiceless, أنا طبعا I'm not questioning the efficacy والevidence, it's evidence-based بالنسبة للaccent method, and we use it with full certainty. But this is the only thing in only the accent method, they're starting with the voiceless. And for voiceless consonants, we know that they require even more air than the voiced counterparts. Have you ever thought about this? Do you have an answer to this? Is there any thing mentioned in the literature regarding why we start with the voices and then we move to the voice?
Yeah, of course. I tried to mention that, to explain this in the session. Usually we start with the simple tasks and then we move on to more difficult tasks. Simply said, during phonation, during talking, I use voiced and voiceless sounds.
Exactly.
So part of my speech, if I can say, or utterance, I use those sounds. So it is good to start with those and to build on. And also one thing more. When I start by asking the patient to say "s," I usually ask him or her to put the hand on the larynx. Now say "s." Do you feel anything? No. She will say. Say "z." Now they feel the vibration. So this shift, this feeling, this appreciation, I feel it is important for the patient to notice that there are some sounds we are using without any phonation or without vocal folds performing. And there are some sounds or part of speech, the vocal folds are vibrating. This appreciation from the patient side, this difference helped us that whether you are speaking with voiceless or with voiced, Yes, I start with simple things, then more complicated, but during voiced, you are adding the voice, the laryngeal part into that. I feel it is good to start gradual before, like the baby talk, baby walk. It's better to stand up, to be able to stand up before starting walking. So it is good to feel that difference, starting from simple, then going to a more complicated. If you feel it is not needed, it depends on you, but my appreciation, I'll be appreciating if start with very simple things and then you go into that. By the way, if this general rule, if the patient is having only few, he can stay with me for few sessions. He's away, he's from, for example, you are in Jeddah, and he came from Jizan, and he can stay only for a few days. He insists on intensive therapy sessions. I can go quickly over those sessions, I mean, the phonation, 1 or 2 sessions. But again, it is forbidden, and allow me to use this strong word, to go into vocal play without controlling breathing. You can omit voiceless, no problem, but if you have plenty of time, it's good to go by the book.
Okay, great. طيب, my question to you girls now, how do you compare the accent method to the resonance voice and to the vocal function exercises and to symptomatic voice therapy techniques? Really quick, and I need to hear from you all. Rana, تفضلي.
So basically what I learned today, and I know as a difference, is that the resonance exercises that we did yesterday had different ways of extending and the voice and all, but it was all going through the same pattern. However, today I learned 3 new accents, if I may call them that. 1 second, because I wrote down the names. Yeah, the largo, andante, and allegro, basically. So these are 3 different ways to produce the sound. So these are different, especially that we have to start with soft, and we cannot start with hard glottal attack. As for resonance, it was voiced.
So do you find the accent method easier than the other 2 approaches in terms of its application?
Well, I tried, but I can't judge. You know, yesterday my stomach was a bit, so I can't judge what was easier. But for me, the accent method was easier to acquire than the resonance. However, I realized that the resonance, we did not use, like, I did not put so much pressure on my abdomen. But today's method, the accent method, no, I use my abdomen for the breathing.
Yeah. Munira, تفضلي. Thank you, Rana.
So, mashallah, Rana said almost everything I thought of, but I'm thinking also with the accent method, there is like a certain structure as well as the resonance. However, I think both of them I loved very much, but I'm thinking maybe I will also counsel the patient, like what feel more comfortable for them to start with. If the case like would benefit from both therapy techniques. However, with the accent, I loved the accents that we tried because I was trying with the Prof Khalid. So as Rana said, it showed like new different ways, and it relay on the abdominal breathing, which is I do believe in, and I always start with. So I'm thinking to start implementing it and like see from there on and how it will go, because this is the first time for me to learn about it.
Excellent. Huda?
Okay, mashallah, girls قالوا what I wanted to say. بس إنه here there's more pressure on the abdominal breathing, and unlike the vocal functional exercises, which is in the oral, in the mouth or in the movement of the lips. So yeah, and it depends on the patient, and it depends on the case and the patient.
Okay, sure, yeah. طيب, Salam, and then Reem.
Yes, thank you, Prof. Khalid, for this informative lecture. For me, I found the accent method is much easier than the resonance and the functional therapy. Because when we were practicing, for example, yesterday, the resonance, it felt a lot of tension and pressure in the area of your larynx and lips, while in this one, it's a bit relaxed. You don't feel, when you say, hey, it's all, all the larynx, the airway, it's all relaxed. So I think it's easier and maybe could be more acceptable for the patients to accept this method of training.
Yeah. Safety. Reem, تفضلي.
Oh yes, I agree with Salam. It's more convenient to use actually. And I was thinking about using the warm-up exercise and I don't know if that's possible, but to start with the warm-up, then the abdominal breathing, then start with the accent method. It's easier for me as a speech pathologist, and it's I think it's easier for the patient.
Okay.
But I don't know.
Okay.
Can I comment?
تفضل دكتور.
Anybody to from our students? Anybody to comment, or I can comment?
لا تفضل دكتور حتى لو.
طيب, let me warn you. Accent method is simple but needs training from your side. One thing. Second thing, the abdominal part is very important and essential, and sometimes it's challenging. It's not difficult. Patients usually can perform, especially voice users. So it's good to believe in Smith accent method, but again, it needs training. It's forced for all types of voice therapy, all types of therapies in our field. It should have some training with observation, and then you can perform it. It's not difficult, but you have the general rules are there. Next point is use whatever you are trained on. I mean, if you are good on vocal function exercises, your results are fine with that, go for it, continue on that. If you are training on other methods and results are okay, patients like it, no problem. It's good to try things, new things. I believe in accent method, but again, this is my training. But like in surgical techniques, usually there are standard surgical techniques, and in some options, some operations, there are more than one type of surgery. Which one to choose? Of course, with more benefits and less complications, but your practice is very important. If you are trained to do certain type of surgery, certain type of therapy, and you have 10 good results, this is the good thing about it. Accent method, next point, the good thing about it, maybe you noticed, especially with vocal function. Vocal function is very simple, lips and whatever, and up and down. But I noticed that it's not giving more time on the speech, in words and sentences. In accent method, you spend some time on that. So you need more time. But some of my patients came to me and they did perform vocal function exercises and other parts, and they came to me and told me they felt fine. They improved with that. So there is no rule like all or none. This is the only. This is not good. Voice therapy is a good thing. And by the way, there is what they call the placebo effect. We should not neglect that. If the patient is coming to you and having some sessions, and he or she is aware of her problem, whatever therapy session you're using, mostly improved. Depends on what? Trust you and your technique and performance outside the session. But I'm very glad that you are thinking about the accent method. You will love it. You will feel that holistic way of it. And again, you have to be attentive. Without attention to the patient during the session and training the patient to be attentive to himself or herself, this will not work. I'm sure with all sessions, but with accent method. These are points I wanted to stress again because they're very important.
طيب, is there any other comment يا بنات before we close? طيب دكتور خالد.
Thank you so much.
اوكي، يعني انا باسم الطالبات وباسم الجامعه وباسمي شخصيا اتقدم بالشكر الجزيل لحضرتك دكتور، والله يعني ان شاء الله يزيدنا دائما من هالمنفعه من علمكم، والله ينفع بك دائما وان شاء الله في ميزان حسناتك. ويعني مهما شكرناك لا نوفيك حقك والله يا بروف خالد.
لا بالعكس،
الله يجزيك كل خير.
نتعلم منكم، بالعكس نتعلم.
العفو دكتور، العفو.
نتعلم من بعض، والملاحظات اللي يعني سمعت عليهم ايضا ملاحظات جيده، انا اشكركم عليها واشكركم على تحت الفرصه، واتمنى كانت اضافه مفيده لكم ان شاء الله.
بالتاكيد، وشكرا جزيلا على دعمك المستمر لنا.
الله يعطيك العافيه.
الله يجزيك الخير. يا من الله.
طيب ان شاء الله، يعطيكم العافيه.
الله معك، مع السلامه. ثانك يو سو ماتش.
مع السلامه حبيبي.
الله يحييك.